Yeah, so this is sort of the final chapter, I guess, of a COVID work that Nargis was very involved in. And so, way back in 2020 we started, and this is the result, I suppose. So we deployed this model into Epic across the campuses of NYU Langone Health. And we were evaluating it with a randomized controlled trial, which is pretty rare. So very cool experience. Just so happened, a bit of a spoiler, that in this case, we didn't see the effect that we were hoping for. But that's the point of the trial. So getting into it here, there we go. So the crux of a lot of our work is the fact that while there's a lot of AI and medicine research out there, a very tiny percentage of that actually makes its way to be implemented in clinical practice. That is the sort of focus of the predictive analytics unit. And a lot of my work, working very closely with Epic, pushing them forwards to allow us to actually do more and more integration pieces, make more sophisticated models, make them more real time, more complicated data, etc. So we think about operationalization, which is really the entire process of how you take a model that uses data and how you actually make it ready to be used in practice, in a system by people, humans. And that is fundamental to that, is that a good model doesn't guarantee success. You need to consider the entire workflow. So what level of risk is actionable? You get a whole spectrum of risk from, say, 0 to 100, low to high. Where do you actually draw a line to say to some human, particularly a user that wasn't intimately involved in the development of the model, what level is high enough to spend X amount of time, X amount of dollars to do some intervention, some extra testing, some workup, some whatever. And fundamental to making sure that these systems are useful live is, can we actually make that risk at a meaningful time point? It's no good making a prediction after discharge. The patient's gone, they're in the wind. So you have to make sure you can do it early with enough time to actually, digest the information, choose to act, and have the intervention do something. We also think about, how do we communicate that risk to the care team? We often rely on our clinical informatics colleagues for a lot of that. We have to think about how the user gauges the patient's risk and decides to act. So that is the sort of the result of the communication, how they actually sort of validate it internally in their own mental model of, say, illness or urgency, and make a decision. And then what is the expected impact of that intervention? What is there maybe one of a small number of possible interventions? And there's a choice of which intervention for that individual patient. And then lastly, off the screen intentionally, is the last piece of this, is evaluation. We have it in the system, we set it up, and we leave it, and we come back and we want to evaluate the model. And most of the time, evaluation is never over. So off the screen. So really quick background on the actual model here. So we published this in 2020, and this focuses on a use case for COVID-19, which is who is likely to be safe to discharge from the hospital. So basically low risk individuals. And what that means is you have none of these bad things in the next 4 days: mortality or hospice, ICU transfer, readmission or return to the ED once if you were discharged, as well as intubation or any significant O2 support that would keep you in the hospital. So fundamentally, as a patient moves through time in their hospitalization, we pick a prediction time, and then we are looking backwards for data and forwards for the outcome. This particular model, we were wanting to make sure that it was interpretable while preserving good accuracy. So the way we do that is we initially train a sort of powerful ensemble-like model, a black box, and then we do a variable selection process using conditional independence tests and things like that. You can see the paper, which yields a sort of distilled set of features that work parsimoniously in a linear model as an output. So basically filtering from a complex model to an interpretable model. So we go from 50 or 60 features, in this case, down to 16, and they work well together with low redundancy while preserving accuracy. So what that looks like in performance curves is, the black box model here in yellow, the parsimonious one in blue. We go down to only a quarter of the features while preserving almost identical performance. For the ROC, actually saturates at the top side because there is some data leakage that we know about. The target having oxygen support is also a variable. It was a decision we made to keep that, because if you're currently on significant oxygen support, you are very likely to continue, and frankly, that's fine by us. We're not going to be using the model in that realm up here in the very high true positives. Instead, we're looking to use the model on the precision recall curve about approximately here, 90% PPV over 50% sensitivity. The good thing about doing this parsimonious model and the fact that it results in a linear model is that we can actually just read the coefficients and they mean something. So the largest negative weighted coefficient is having oxygen support above nasal cannula, which makes sense. But again, if you're currently on that, you're going very, very likely to continue, and that's fine by us. We put those people in a high risk category, and that's fine. That's not where we're expecting to use the model. But you can also see things like max oxygen rate is a good thing. Things like eosinophils pointing upwards, platelet counts the same. So fundamentally, this is the entire list of variables the model takes. So for deployment, what this looks like is we actually pick 3 different color zones. We have green above 90% PPV, orange between 90 and 80% PPV, and then red is the remainder. And so we're going to communicate these to users, nurses, physicians, as green, orange, and red, low risk, moderate, and high. Since the coefficients are from a linear model, we can also output exact contributions from the model by the value of the variable times the coefficient. In this case, the variables are all standardized, so they're in a sort of a dimensionless space. So the graphs here are somewhat normalized, but we return that back as a percentage to the user, which we'll see in a second. So here's an example of a green, an orange, and a red. So you can see they have very different scales, very different combinations of variables. So what that looks like in EPIC is a type of EPIC scoring system, which is cloud-based. Effectively, the computation is done in the cloud. It's not really important, but it's one of the now preferred ways of doing these models. It means that we can schedule the model to run every 30 minutes. So every eligible person, a patient with COVID-19 who's an adult, can have a new score every 30 minutes, and they sort of update through time. And we see, for example, this trend line as each score continues. So fundamentally, it is displayed in this column, the COVID-19 low risk of adverse events, and then when you hover over an individual score, you see this pop-up bubble, which contains much more information. That same information in the bubble can be shown in a print group in a COVID-specific summary report. So we did that as well. There you'd view one patient at a time. In the list, you'd view a group of patients, say your patients, the patients in your department, or all of the patients in Tisch Kimmel, for example. Again, they're color-coded, but we made some customizations for this individual model, such as limiting to only the top 9 largest in magnitude variables by contribution. So you can see here in this little table, we have the largest positive. We also have the largest negative, because default by Epic at the time is to show the up to 9 largest positive is larger than negative. And so you never actually see what these predictive variables are. So we actually omitted those, made sure that, because in our use case, we wanted to see what is predictive. For example, the platelet count being 310 or the O2 device being non-room air. It's a very, very good sign that this COVID patient is actually doing fairly well. So we wanted to make sure we showed that. If there was missing data, particularly vital signs, so that the model couldn't actually make a reliable score, we show that, because the alternative is to show an NA, which makes sense to us as data people, but doesn't really make sense to nurses or physicians. And the other thing is we actually chose to randomize patients into a control and intervention arm. And so the control arm had scores produced, but they were hidden to the user. And so the word hidden was returned. It's impossible, if you hover over this, you see nothing in the bubble, it's just a gray box saying NA. So that really leads us up to the RCT part of this work, which is the hypothesis is as patients go green, the care team can prioritize discharge planning, which would lead to a reduction of length of stay after identification of the fact that they are green. The intervention, again, is displayed only for half of the patients, and the outcomes primarily is the green length of stay, the length of stay after going green. Also looking at the entire length of stay from admission to discharge, and also looking at some safety indicators, death in hospice, readmissions, and representation to the ED in 30 days. So we did this at the 3 general and 1 orthopedics specialty hospital at NYU Langone Health. Enrollment, the eligibility was you had to be hospitalized, a hospitalized adult with an active COVID-19 infection, who was admitted in the study period between May 15 and December 7. You had to be discharged alive to be in the primary set. You could be in the safety analysis if you had died. You had to be scored by the model at least once and have at least 1 green score, again, to be in the primary cohort. And so the trial was approved by our IRB and registered clinical trials. So that the results, we power calculations, so we wanted about 1,000 patients, so we went until we surpassed that. We had 1,010 patients meet eligibility, 513 allocated to intervention, the remainder to control. Looking at safety indicators first, so this is a wider cohort of patients because it includes those that went to the ICU, those that died, those that were never green, for example. And so 14, 15 there. So any bad indicator, we see no difference. In the intervention, 26.8 versus 25.3. The green length of stay, which is our primary outcome, again, that's the time between the patient first going green and then being discharged alive, was also similar between both groups. 3.18 median versus 3.23, very, very similar. Among all patients, the green length of stay was longer in men, in older adults, in non-Hispanic white patients, and in the first 2 months, and those with primary symptoms of COVID. So, that's having primarily respiratory issues, for example, not being admitted secondary to their COVID infection. And so we did a gamma regression without race, so to control for these different things, showed no intervention effect there either. So I think this is a very heterogeneous population. We see these, what looks like trends but fundamentally the display of the score did not lead to a lower length of stay. Briefly, the only other sort of major result in the paper published a couple months ago was this idea of adoption and sustained use. So we were using epic metrics of how often the score was displayed, both primarily in that patient list that I showed you, and also in this single patient at a time report style display. So we see the colored dots are the number of displays. The gray is the COVID census, the number of people admitted with COVID on that same week. So you can see, the number of people with COVID was just hugely dropping off early in our study time, and then sort of plateaued to the summer and then started to rise again. So we were in this sort of low spot at the current sort of surge criteria in New York, but we see pretty uniform counts of displays through time in the patient list, which makes sense with the same sort of captured user base that is seeing the displays. Whereas at the patient-specific report, it's one patient at a time that follows the census trend much more closely. Over here, we see approximately 4 displays per patient, which is pretty uniform across time. So we feel like people are relatively regularly using the report, seeing the score, but that number 4x is probably low, on the low side. So that doesn't mean once the patient's gone green, right? That could be throughout their stay. So it could be that we're not actually having regular enough checkpoints where users are seeing the score to see, oh, hey, that's gone green. We should think about discharge planning. So that sort of brings me to what went wrong. So, briefly, you might have your own thoughts, which I could poll in a second, or you can put them in the chat. But I have about 5 ideas of what went wrong. So one is it never worked. The model was literally never accurate. The changing disease means that early data won't generalize to later data potentially. So these are performance curves from the 3rd surge, the Delta variant. So that's the sort of summer of 2021. And we can see it's still pretty accurate. The ROC is pretty good. There's a sort of weird flat spot here, and the PR curve with not much sample up here, but it's actually pretty strong. So we would still end up with about 90% and about 50% recall, which is pretty similar to where we thresholded this thing. So we think the model still works on paper. It's probably more likely it is an operationalization issue. So I sort of touched on this already, but likely we missed our opportunity. We went as fast as we could. We got this model live in 2 months, which is very, very quick for both pulling of data, making of a model, clinical validation, prospective validation, and epic build and go live in the system in 8 weeks is very, very good. But already by that stage in New York, we were certainly at the tail end of that first surge. So we were missing a lot of patients. We were already sort of getting into our status quo of how we treat COVID patients. Maybe we had missed the opportunity for really education type things, helping users get up to speed managing COVID patients. And then, like I said, we ended the study once we got to 1,000 patients, just as that winter surge was picking up, which is quite unfortunate. So the third hypothesis is that discharge readiness is not equal to being medically stable. So the model was developed for COVID-19 and overlooks the effects of additional acute or chronic conditions. So being, safe from a COVID perspective doesn't actually mean that they look safe for discharge clinically. There could be other, perceptions of what it means to be stable. So for COVID, initially people were thinking about having no fever for 48 hours, for example. Some people needed to actually test negative by PCR so that they could be discharged back to where they live, say a skilled nursing facility or a nursing home. And so, the patient might have been green for days, but they were still testing positive. They couldn't leave. That's really the last point here, is medical stability is not the sole driver of discharge readiness. There are also other things like social needs. Number 4, adoption is not equal to trust or reliance. So we saw, a very quick adoption that then sort of persisted through time, which I'm very pleased about. But it may have been dampened due to issues of distrust or algorithm aversion, which is this idea that as humans, we are forgiving of other humans as being, imperfect. But when we see an AI model do something and make a mistake, we're more likely to carry that bias forward and start to, actually no longer trust the model. So clinician experiences caring for patients with COVID-19 involves learning and observing the risk scores could have, hypothetically, expedited development of their mental model of what a COVID patient looks like and when discharge readiness of those patients. But that would actually, in a feedback cycle, diminish the model's utility. So number 5 is awareness is not equal to adoption, not equal to being notified, not equal to being empowered. So uptake of the intervention may have been limited by insufficient outreach. So we spent a lot of time in those first few months going out, speaking to nursing groups, provider groups, sort of town hall-like events, publicizing the model to those users. But we still very likely did not reach everybody. This was in May. It was sort of about the time that the quote-unquote COVID army was sort of finishing up, and we were going back to primary, internal medicine physicians taking a lot of the bulk patients. And so maybe we missed out on the opportunity to get out to all those other groups. The tool was communicated very broadly and lacked specificity of who would be responsible for reviewing green patients and advocating for their discharge. So it's unclear from a sort of care team dynamic perspective if this should have been primarily by the nurse, a care manager, a physician, a resident, who is actually supposed to be, taking ownership of looking at the scores and then also speaking up at rounds to say, this patient's probably good to go. And the CDS implemented was also sort of insufficiently relying on regular checking. Like I mentioned, this 4x ratio, which likely causes very significant delays in awareness of patients being green. If someone checked their patient list at the start of every day, they could see the score, but if the patient converted, relatively uniform to green, relatively uniformly throughout the day, they could have had an average of 12 hours being late by the first time that user saw that patient was green. So with that, I would take any questions, any more thoughts about why this didn't work. And I think I'll just comment that a couple of months ago, we decided, given the climate of COVID really decreasing, seeing many fewer sort of primary COVID patients in the hospital, the ubiquitous use of vaccinations and boosters, we decided to actually sunset this model. So it means that we turned it off. We made the columns inactive, and so we have sort of closed this chapter.